Welcome to January 2021 CME. This month we're going to be talking about high-risk chief complaints. First, we're going to get started talking about chest pain. The differential diagnosis for chest pain can be very long. Several of them are non-life threatening, but a few of them have serious potential. There's cardiac, respiratory, GI, pathophysiology of a diagnosis. There's what a patient can tell you. There's typical versus atypical, angina versus anginal equivalents, associated symptoms such as shortness of breath, nausea, coughing, dyspnea on exertion, orthopnea, palpitations, weakness, or just something just isn't right with the patient. What you'll see with the typical and atypical, what you should do, and how we'll go ahead and tie the protocol in together where it's actually applicable, okay? So now we have clinical presentations, signs and symptoms. When we hear chest pain as a complaint, what are our first thoughts? Most of the time, with an older adult, we think heart attack. Consider other highly critical issues that present as chest pain, not just an MI. So we need to look at the complaint of chest pain with broader goggles. We use the term pain as a general reference, but sometimes it could be described as a discomfort. It's important that we use terminology or phrases that the patient describes, such as squeezing, heaviness, stabbing, aching, discomfort, tearing, but sometimes they just say, it just hurts. So we want to go ahead and get the correct description of the pain without leading the patient along down that road. Using these descriptions can help us lead to more definitive differential diagnosis. Make sure that the description is documented as described by the patient. Other clinical presentations could be shortness of breath. Many cardiac issues cause shortness of breath. Be mindful that the respiratory drive will be the first thing that changes when the body senses shock. Lightheadedness, syncope, subtleties can be overlooked. There are many instances of cardiac issues that do not result in chest discomfort, but be vigilant clinician and thorough during your assessment. That way you can go ahead and pinpoint what exactly is going on with the patient. Skin changes are always a good sign for you to go ahead and look at. Cool, pale, diaphoretic is not normal. Skin conditions can show a clear sign of shock somewhere in the body. Always be suspicious when a patient, even with the transient skin changes. So if they're cool, pale, diaphoretic, that's the release of the catecholamines, and you want to go ahead and pay special attention to that. Nausea and vomiting usually represents something internal that triggers this response. Throwing up blood or coughing up blood, those can be indicators of other clinical issues with a complaint of chest pain. Here we have a list of some of the less common possibilities for our differential diagnosis. While most of the time, if it looks like a horse, says neigh like a horse, it's probably going to be a horse, but it could be a zebra. So we need to go ahead and know what zebras look like when we see them, and can you pick out the zebras from this list? These patients may present with classic signs and symptoms of pressure, aching, burning, with radiation to the arm, across the jaw, or across to the chest. But not every single cardiac acute MI is going to have these clinical presentations. They may complain of difficulty breathing, indicating an increase in oxygen demand. And remember, the first time that the body senses some type of shock, that's inadequate tissue perfusion, the respiratory system is the first to respond to compensate. Be very wary of the patient who just says, I don't feel right. They know themselves better than you do, and you should trust them. If they have that look in their eye that they're going to die and they say, I'm going to die, listen to them. You should always be careful to avoid assumptions based on what the patient may have told you in the past. You should not skip doing a 12 lead if the patient tells you that 2 hours ago they were at the clinic, had chest pain, and it was only heartburn. You still have to have that high index of suspicion when it comes to these patients. With cardiac patients, especially with suspected ACS, an early diagnostic 12 lead takes priority over starting the assessment pathway. Once this is completed, then continue with the assessment pathway moving forward. The goal is to have the 12 lead completed within the first 5 minutes. Remember, in protocol C3, STEMI alert and pre-X STEMI alerts are different. A STEMI alert is greater than 1 millimeter of ST elevation in 2 contiguous leads, while on the other hand, with a pre-X STEMI alert, the ST elevation must be greater than 2 millimeters in 2 contiguous leads, as well as a heart rate less than 130, age between 30 and 90, ability to give consent, no DNR, no significant arrhythmias, non-pace rhythm, and early transmission is also important. Remember that you must include the name and date of birth of the patient prior to transmission, so make sure you put that in before you get the 12 lead so you don't have to perform another 12 lead. 12 lead interpretation is an important function of the initial assessment of the patient complaining of chest pain. We need to maintain an organized approach when reading the 12 lead. The rate, the rhythm, the access intervals, ST segment for elevation or depression, and then the Q waves. If the patient does not show STEMI, we should now be working through the assessment pathway. Initial observations of the scene and the patient. Our first impression, sick or not sick. That way it helps build an initial differential diagnosis. We're going to get a detailed assessment. We're going to go ahead and get the history, onset, OP, QRST is a very successful way to go ahead and narrow down what the chief complaint is for the chest pain. Secondary physical exam including vital signs, diagnostic tools, and then you refine your differential diagnosis after completing the assessment. Ongoing assessment after treating and the results. Now we should be working through the pathway. We will be able to narrow down to include or exclude any potential differential diagnosis, starting with the listing of differential diagnosis based on the patient complaint. The OPQRST information will help with looking at the events leading up to what is going on, in other words, the history of the present illness. Sampler history provides background information of the patient. All of this is important, but prioritize allergies, medications, and history. And of course, make sure you perform a thorough physical examination. For pre-hospital management, remember that C3 is not a chest pain protocol. It is a suspected acute coronary syndrome protocol. If there is no suspicion of ACS or MI, then refer to M13 for pain management. If you don't suspect a patient's chest pain is being caused by an MI, then you don't need to give them nitro. If a young male is complaining of chest pain after being struck in the chest with a softball, would you give him nitro? I hope not. Also, remember that definitive treatment for acute coronary syndrome is either thrombolytics or a PCI facility. We are only starting the treatment as we get them to definitive care. Remember that this is your initial differential diagnosis is based on your first impression and the patient complaint. Refining the list is based on history and assessment. This is where we narrow down the possibilities. Further refining is based on the patient's response to our treatment. After completing a history and physical exam, we can rule out trauma or pneumonia. Acute MI can be present without chest pain in the elderly or diabetics. Other possible presentations may include syncope, acute confusion, dizziness, lightheadedness, or just generalized weakness. Always consider ACS in the elderly and diabetics without chest pain. Their complaint may be vague and non-specific. Something's usually just not right. In aortic dissection, the true definition is the disruption of the intimal layer of the aorta, allowing blood to track within the media. Simply put, the creation of a false lumen in the aorta where blood collects. And even more simply put, it stretches out and could lead to an aneurysm. A thoracic aortic aneurysm is a bulging, weakening area in the wall of the aorta in an abnormal widening or ballooning greater than 50% of the vessel's normal diameter. The most common way an aneurysm is discovered is by accident with chest x-rays. Symptoms of a thoracic aneurysm may include, but are not limited to, the following: pain in the jaw, neck, or upper back, pain in the chest or the back, wheezing, coughing, shortness of breath as a result of pressure on the trachea, hoarseness as a result of pressure on the vocal cords, difficulty swallowing due to pressure on the esophagus. An aortic dissection begins with a tear in the inner layer of the aortic wall of the thoracic aorta. The aortic wall is made up of 3 layers of tissue. When a tear occurs in the innermost layer of the aortic wall, blood is then channeled into the wall of the aorta, separating these layers of tissue. This generates a weakening in the aortic wall and the potential for a rupture. An aortic dissection can be a life-threatening emergency, as I'm sure you can figure out, because if that pops, they're going to die. A commonly reported symptom of acute aortic dissection is severe, constant chest pain or upper back pain, sometimes described as ripping or tearing. The pain may be migratory, moving from one place to another, according to the direction of the extent of the dissection. Some of these signs and symptoms are similar to an acute MI, but are more associated with dissection. So get a 12 lead early to help you with your differential diagnosis. If the patient does not show a STEMI, we should be working through our assessment pathway. Initial observations of the scene and the patient, first impression, sick versus not sick, to begin to build an initial differential diagnosis. Detailed assessment, history, OPQRST is very useful when it comes to the complaint of chest pain. Again, the secondary physical exam, including vital signs, diagnostic tools, refine the differential diagnosis after completing the assessment. If the patient does not show a STEMI, we should be working through the assessment pathway. Start with listing the differential diagnosis based on the patient complaint. The OPQRST information will help you look at the events leading up to what's going on, in other words, the history of the present illness again. Sampler history provides background information of the patient, and all of this is important, but prioritize allergies, medications, and history. And of course, make sure you perform a thorough physical examination. Clinical presentation as O2 for shortness of breath, maintain pain management if indicated, and a position of comfort. IV fluids should be given cautiously if the patient is normotensive. Do not give fluids to the patient if you only give it if they're hypotensive. Treating hypertension in the field is not indicated here. The rebound effects can be extremely dangerous. You basically don't want to put more fluid or volume in there, causing it to rupture. Remember that your initial differential diagnosis is based on your first impression of the patient's complaint. Refining the differential diagnosis and the possibilities is based on further history and assessment. Further refining is based on the patient response to your treatment. Sudden aortic dissections are highly lethal with 90% mortality rate if left untreated. Chest pain with associated back pain is the most prevalent symptom of aortic dissection. Pulmonary embolism. The definition is an obstruction in the pulmonary artery system due to a clot. Most common causes of PE are immobilization, recent surgeries, hypercoagulation. Sometimes patients with sickle cell and are dehydrated could also suffer from a PE. Pulmonary embolism is the great imitator. Cyanosis from the nipple line up is not reliable or a common sign. The list and signs of symptoms of a PE can be extensive and they do vary. Based on that, a pulmonary embolism is noted as a great imitator due to its large variations of signs and symptoms. There has been some information about suspecting a patient having a PE based on cyanosis from the nipple line up. This is not a reliable way to go ahead and determine or even a common sign. Once the patient does not show a STEMI, we should be working through the assessment pathway. Initial observations of the scene and the patient. First impressions are sick or not sick. Begin to build the initial differential diagnosis. Detailed assessment, history, OPQRST is very useful with the complaint of chest pain. Secondary physical exam include vital signs, diagnostic tools, and then you can refine your differential diagnosis after completing the assessment. Of course, you're going to continue your ongoing assessment after treatment and go ahead and look at those results and how they present with it after. Treatments for patients with PEs, you're going to go ahead and give O2 for shortness of breath, pain management if indicated, and transport them in a position of comfort. Start with listing the differential diagnosis based on the patient complaint. The OPQRST information will help looking at the events leading up to what's going on. In other words, again, the history of the present illness. Sampler history provides background information for the patient. All of it is important, but prioritize allergies, medications, and history. And of course, make sure that you perform a thorough physical examination. When we don't find a STEMI on the 12 lead, we need to focus on the patient's recent history. We need to be asking lots of questions and listening to those clues that may lead us towards a diagnosis of a pulmonary embolism. Here you can see a list of all the possible causes. Think of all the questions that you may have to ask to hit all of these possibilities. Make sure that we're performing a 12 lead for all chest pain patients who don't have a knife sticking out of their chest. Make sure we do not exclude acute coronary syndrome even if the 12 lead doesn't show a STEMI. Chest pain to the back is a more prevalent symptom for these patients. Keep in mind, there are other chest pain issues which can be life-threatening. Working through the assessment pathway will help you narrow these down. We treat chest pain, not hypertension. So if you are treating a patient and note that the patient's pain has reduced, it doesn't mean that a dissection does not exist.